Good evening, everyone. Thank you for joining us for Black Lives Matter Charlotte. It's a conversation that we hope to have with you and our program participants. And we hope that it is a discussion to the extent that it can be while we're all in our separate and individual spaces. Black Lives Matter Charlotte is an initiative of the Charlotte Post Foundation, and I'm going to share some information with you with respect to how we got here and what we are hoping to accomplish with these kinds of conversations. Anthony, you'll have to tell me if the slideshow is showing. I'm attempting to share my screen, Anthony. And we will go through a few slides, and then we'll keep the conversation going. Technology is awesome until it is not. So let's get started with a few slides. So Black Lives Matter Charlotte is a conversation. It's a space, it's a place that the Charlotte Post Foundation launched back in 2014. And it was our intent to be in solidarity with the national movement. As many of you probably know, these three women are the founders of Black Lives Matter. And we always bring their names into the conversation because we don't want to seem as though we are misappropriating their great work, their bravery, and their courage. Our effort locally was to stand in solidarity with them as a way to call to consciousness this statement, Black Lives Matter, a call to action for Black people, a call to action for our allies, and definitely a call to consciousness about the degree to which Black Lives Matter. What we focused on in 2014 and what we're still focusing on now, and it'll be a part of tonight's conversation, are the disparate outcomes that Black people experience around these four key areas: around health, around education, around economic mobility, and around crime and justice. These are areas that we must improve, that we must address, that we must question, that we must interrogate, that we must figure out how is it that Black people are experiencing such negative outcomes and experiences across these four areas, how and why, and what we can do to change it. As a part of the framework that we created back in 2014 and since then, we've been asking audiences to do these four things: to become informed, to engage in discussion, to make some decisions, and then choose to act. And each of us can do all of these, and we can do them in ways that's authentic to each of us. We ask our audience and we ask ourselves, if we want change to happen, how can we make it happen at these three levels, which we think are requisite? First, at the individual level, what can we do as individuals? What do I have responsibility for as an individual in this community? Then we ask, what can we do as a collective, as a community? What is our collective call to action? And then fundamentally, we have to address the systems that are currently creating the very outcomes that we don't want to experience. So while we can have conversations at an individual level about our interpersonal and intrapersonal differences, and while we can come together as a community and have conversation and discuss and decide, at the end of the day, the systems that are in place that are creating the disproportionality have to be what we address, have to be what we dismantle. While we are becoming more educated and becoming more conscious and becoming more active, we always have to keep in mind that it is the system at work that's impacting us all. So in these spaces and places, we call them the gatherings. And we call them that as homage to where I grew up in South Carolina. My grandfather and uncle would call the family together whenever we needed to discuss a problem, whenever we needed to discuss what was going on in the family. They called us to the hill. They called us to the house, and we had to have a conversation at my Bubba George's house was his name. And in that space, we had honest conversation. It was a brave space where we talked very candidly about what was wrong. We also wanted to make sure that all the voices were heard. So the children in the space had an opportunity to voice their opinions. The elders in the space had an opportunity to voice their opinions. And then we embraced the discomfort, believing that if you want to build muscle, you have to tear it. So these gatherings are a space where we want brave conversation. We want a diverse audience to be a part of the conversation. And at the end of the day, because we're talking about race, because we're talking about disproportionality, because we're talking about disparate outcomes for people of color primarily, we have to embrace that discomfort. And in embracing that discomfort, I think we might be able to have some good conversation in order to have some good solutions. This is one of my favorite quotes. Not everything faced can be changed, but nothing can be changed unless it is faced. And that is by James Baldwin. So tonight for our conversation, we are going to share some information with the audience, and we're going to invite you to engage with us and ask your questions. We're talking about health and race and COVID-19 and what it's doing to us. And let me introduce tonight the participants in this conversation. First, we have Dr. Tom Hanchett, historian in residence at Charlotte Mecklenburg Library. Thank you, Tom, for being with us. We also have Gibby Harris, Director of Public Health, Mecklenburg County. We appreciate you being with us tonight. We also have Dr. Jerome Williams, cardiologist and Senior Vice President for Consumer Engagement with Novant Health. We're glad you could join us, Dr. Williams. And we also have Melba Newsom, R.J. Reynolds Institute Fellow and reporter with the Charlotte Post newspaper. Thank you, Melba, for being here. And Herb White, editor, the Charlotte Post newspaper. Herb, thank you for being a part of the discussion. Now, I've talked a lot and I've introduced the participants. We're going to get started with grounding us in some shared understanding. It's a part of the experience we try to create in this space to make sure when we're having a discussion, we start from a shared level of understanding. So we're going to get started with a presentation by Dr. Hanchett. He's going to help establish what's in the ground. The past is always prologue. Dr. Hanchett, I'll turn it over to you.
Thank you so much. I'm honored to be here with you all, and particularly grateful to the Johnson family who has done so much over so many years with the Charlotte Post. Thank you all for letting me be here this day. I could talk for hours about Charlotte history. I frequently do, but I'm going to do about 5 minutes here. I want to talk about how this city has become segregated by race, segregated by class, and lay a groundwork for the fact that that really plays into any stresses on the system that we currently experience. And COVID is a huge stress, and a lot of the tough stuff is falling on people of color, and that comes out of a history of systemic racism. I'm going to ask Anthony Chadwick, who's our IT person, to pull up some slides and just real quickly show you what I mean by that. I've written a book recently, well, a while back actually, called Sorting Out the New South City. And it's about how Charlotte got segregated. And you may have encountered the book, The Color of Law by Richard Rothstein. This is the national version of the story I tell locally. So bring that slide up if you would. And the book tries to make 3 points. It talks about racial segregation and economic segregation, neither of which existed the way we expect them to today until about 1900. If you'd asked me when the South got segregated, I would have said it's always been segregated, or after the Civil War or after Reconstruction in the 1870s. No, actually around 1900, there was some big stresses on the system. The white supremacy campaign of 1898, you may have heard of that in Wilmington, it was here in Charlotte as well. So segregation was created. Segregation is the result of choices that policymakers made and other folks made over time, kind of layered on top of each other. So what we're dealing with right now is a playing field that we didn't create. We get to play and push and change and make better, but understanding how the field got set up is really powerful. Next slide. So normally I will talk about a bunch of different neighborhoods, but today I want to specifically talk about the Brooklyn neighborhood, which a few of us experienced firsthand, many of us have heard of. Brooklyn is where the government center is today. Brooklyn came into being as a response to that awful period of disfranchisement around 1900 when African Americans were literally displaced from moving into new suburbs. All of the suburbs around the center city around 1900 got restrictive covenants in their deeds. Plaza Midwood, where I live, Dilworth, Myers Park, Villa Heights, all of those said members of the Caucasian race only. And so African Americans tended to move in and kind of clump together in a number of neighborhoods. The greatest of the neighborhoods was Brooklyn, a city within a city named after the borough in New York that's a city within a city. And it had every different kind of Black folk. Up on the upper left, you see the home of J.T. Williams, a physician and diplomat. He was our top U.S. diplomat to Sierra Leone and West Africa. In fact, that's his portrait at the upper right. Another doctor on Brevard Street there, the Grace A.M.E. Zion Church that still stands. Come straight down and you see the Black Main Street, the Afro-American Mutual Insurance Company built by a Black architect, first Black public library in North Carolina off in the distance. Education, very important to Second Ward, as they called it, that Second Ward High School at the heart of Brooklyn. And at the lower left, you see a lot of the housing stock was working class housing that was not owned by folks in the neighborhood. A lot of absentee land ownership. And the absentee folks somehow never got quite around to painting the house, as you see there. There's a lot of disinvestment baked into the beginnings of Brooklyn. But Brooklyn was a complete city. You could buy what you needed. You had neighbors to help you out, all that sort of stuff. Next slide. So what happened to Brooklyn was that over time, it was picked on. What you see on the left is redlining map. Redlining is now illegal. But back in the 30s, the federal government did redlining. Redlining is drawing a red line around a neighborhood and saying, you don't want to invest there. The government was not really focusing on that. The Depression was on, banks would not make loans. And so they sent people around to do credit mapping. So they talked with the real estate leaders. They said, what are the good credit risk neighborhoods? Colored them green and blue. And if you look at that map, at the lower right is Myers Park and Eastover. This is the left-hand map, the redlining map. Dilworth is there, Elizabeth in blue, the Plaza Midwood area in blue. African-American neighborhoods were all marked in red, which meant that even if you had the money, like J.T. Williams did, if you were J.T. Williams' younger neighbor, go to the bank with your cash in hand, they probably would turn you down. So that's why redlining was not really good. And what was worse is that other decisions layered on top of that. On the right is the zoning map. Charlotte started zoning in 1947. And the colors are slightly different, but green is single family. And you can see all the single families in the same lower right-hand part of the map that the quote unquote good neighborhoods were back in the 30s. The fascinating thing is how Brooklyn fared in all of this. Next slide, and I'll pick out Brooklyn specifically. On the left, you can see that Brooklyn in that circle on the left-hand map is redlined, the whole neighborhood marked for disinvestment, including the fine homes on Brevard Street, the businesses on 2nd Street. On the right, the zoning map Yellow was the least desirable category that was quote unquote industrial. You can see that Brooklyn, all of Brooklyn, all those homes are marked quote unquote industrial. Doesn't mean that they're immediately going to build factories there, but it's a big signal to those absentee landlords, hey, no need to paint that house. And so you start to get this cycle of disinvestment. And next slide, it gets worse. In the 1950s and 60s, there was federal money for quote unquote urban renewal, for wiping out what they called slums. Well, slums were an area where there was a lot of disinvestment. Brooklyn did not qualify initially because it had homeowners, but eventually the federal regulations wiggled a little bit and down came all of Brooklyn. 1,000 families displaced, 200 businesses closed, a dozen churches kicked out. And when we talk about intergenerational wealth accumulation, that's one of the markers from the Raj Chetty study. That's how opportunity builds from generation to generation. Your grandfather passes property down to your mom passes down to you. This breaks that intergenerational wealth transfer. And so understanding how much a disadvantage history has created is really hard for white people like me to get a handle on. I think African Americans have heard this, though they may not have seen the documentary proof. For white decision makers, this is often new information. And so as decisions are made in response to COVID, it's powerful for all of us to have this in our minds. I'll leave you with one anecdote. I get to give tours for folks in Charlotte who need to get to know Charlotte. We have so many newcomers. And I was asked in early March to help lead a tour for emergency room doctors. New folks to our community, most of them, they deal a lot with indigent people. And so they wanted to see different parts of the city. And we went, among other places, to Urban Ministry, which is an amazing organization. So warm of heart, volunteers, cooking food, helping people who were there. You could see that they were in hard times, but they felt honored. I felt very good about Urban Ministry as something that Charlotte does. But as I looked around, nearly all of the clients of Urban Ministry were African American. And when you think about the way that intergenerational wealth transfer has been systematically cut, you get a housing crisis, gentrification, who gets pushed. That's what I thought that day. The next day came the lockdown for COVID. Who's going to get hurt worse? And indeed, as our other speakers talk, they will tell you that people of color, because of this historic racism, have a hard time.
Thank you, Dr. Hanchett. I have one question that I'd like you to maybe speak to just a bit. In a lot of the neighborhoods that were historically Black and right now are predominantly Black in Charlotte, what kind of industry occupies some of those places and spaces, and were those industries good for our health?
I'd say the last words again, I'm sorry.
Were those industries good for our health?
Ah, boy, what a great question. I have not thought particularly in that direction. Many African Americans were service workers, maids, and there was a whole class of errand runners, which is now handled by the internet and Amazon and things like that. So that was a lot of the thing. A lot of the hard labor at places like Charlotte Pipe and Foundry or the Highland Park Mill, which is now Heist Brewery and NODA, the folks who picked up the cotton bales and moved them where they needed to go, the people who handled the hot iron coming in to make the pipes. I think that what you're getting at, I'm not being as specifically helpful as I can, but traditionally, African Americans had to do the jobs that a lot of other folk did not want. And those jobs were either dirtier or harder or more hard on your health.
Thank you for answering that. I was curious about that because I know as development happened, even in Charlotte, the highway system that we now traverse on a frequent basis cut through communities. And so the fact that we are talking about green space or the absence of green space, we talk about the social determinants of health and the degree to which space impacts a person's healthiness. If you look at some of these historic communities that are Black, they don't have a lot of the same amenities that other communities that are majority white have. So there's an interplay, and it always has been an interplay in space and place and health. And we've done that by design as well. So I'm going to transition us a little bit to our next presenters. They're going to be our journalists, and they are going to ground us in stories. Dr. Hanchett told us about the past in the prologue, how we are experiencing, really, as my grandmother would say, chickens coming home to roost in many ways, in terms of what the place has undergone. I'd like for Melba and Herb to speak a little bit about the stories of what's happening with people right now in the midst of this pandemic. I'll start with you, Melba. I think you might be on mute.
I know I am. Okay, so thank you. I'm off mute now. Good evening. My name is Melba Newsom, and I am a journalist here in Charlotte, an independent journalist working on a lot of different stories that concerning COVID. And we've all heard this statistic about Charlotte being 50th in the largest cities in terms of economic mobility, how tough it is to move out of whatever class you're born into or economic condition you're born into. So Dr. Hanchett has explained the history of that has led us there. And so I've been reporting on what keeps us there in terms of healthcare, specifically what's happening in our communities right now. I'm going to stay focused on coronavirus. So what's happening in our communities that made us so hard hit? And why are we at the mercy of this disease more than any other population? And what can we do to change that? So I received a grant from the Pulitzer Center for Crisis Reporting to cover the lasting impact of the coronavirus on Charlotte. And that's what I've been working on. And I'm trying to tell those stories of the people who are affected so that we can see how this access and disparities of everything from healthcare to housing to incarceration to the way our communities are policed to socioeconomic inequalities, how all of those come together in this situation, because we as a community, if everyone else has a cold, we get pneumonia. That's just how it is because of where we are in the economic structure. So in my reporting, I hope we can discover not just what needs to change to address these disparities, but how we can achieve that change. I hope we understand that we didn't get here in this position because somebody somewhere didn't do enough to merit equity. I hope we understand that we are here because of systemic inequality and racism that has left too many of us in the community bootless. So to tell us to pull ourselves up by our own bootstraps, as Dr. King would say, is a cruel irony. So we've seen there have been some places that have produced positive outcomes, and I hope that my reporting can reflect that, what we can do in underserved communities like in Charlotte to turn that trend around. So right now I'm publishing one enterprise story a month over a 6-month period, and they will be published simultaneously or together in the Charlotte Post, the Charlotte Observer, and North Carolina Health News. So we take a close look at a way that this disease is impacting the Black community in particular. And so one of those is earlier this month, I did a story about a woman who has kidney disease and has been waiting for a transplant. So we are learning about this disease because we first started out, they were looking at it primarily as a respiratory disease. Now we understand that it has a dramatic impact on the kidneys. And kidney disease is 3 times more prevalent in African Americans than in white people. So right there, you see how this is going to hit us harder. So this young woman has been waiting on a kidney for 2 years, and this has extended that wait because the coronavirus pandemic has also upended the transplant system. So we already waited longer for kidneys as Black people for transplant, and now we'll wait even longer. So, and my next piece, story that I think will come out in the middle of August is about housing. We think of housing as an economic issue. It is also a public health issue, especially when we're in a pandemic. If you don't have a place to go, it is not just an impact on your health, but the health of the community, because you're not able to contain or isolate. And with the moratorium on evictions coming, ending, we are going to see a lot of people lose their housing. So we really need to address that as well. And that's what I hope to do. So in the next couple of months, as I cover this issue, I want you to, contact the Post and let me know if you think there are stories that we need to report on that are going on, that are being undercovered. One final thing I want to say is that in my reporting, I see that our health officials, both here and statewide, are doing a good job trying to put in place policies that will help us stem the spread of this disease, because our numbers in Mecklenburg County are off the chart. But those policies are not being enforced. I see lax enforcement. And until we get that together, we're not going to reverse that trend. So that's another thing that I want to talk about, is how I want you to keep in mind is how we can connect neighbor to neighbor, friend to friend, to make sure we're doing all we can for this. But in the meantime, thank you for attending, and thank you for supporting Black Lives Matter Charlotte.
Thank you, Melba. Herb, what stories are you hearing and telling?
Well, to piggyback on what Melba said, it's hard to follow what she said, but I'll give it a try. Since the pandemic really took root in late February, early March, we've been reporting on the health as well as the economics of COVID-19 and its impact on Black Charlotte and Black America, period. When you look at the health side of it, there's all kinds of data out there about underlying conditions, pre-existing conditions, and how COVID basically uses that as a trampoline to wreak havoc on bodies. And in some of the reporting, for instance, that I've done, there's a direct correlation between where you live and industry and how sick people are. In Charlotte, there are neighborhoods, specifically in urban areas, in the urban part of the city, on the west side, where air quality is the worst in North Carolina. These are where a good chunk of the neighbors are Black. Asthma, COPD, all those underlying conditions are more prevalent on the west side near the interstates than, let's say, in Myers Park or Ballantyne. And when you have people who have these underlying conditions, they are sick already. COVID comes along, and in many instances, they are getting sicker, and in some instances, dying. So where you live, your zip code is almost a precursor to how COVID will treat your community. On the economic side, the city has come up with programs to where businesses that have been impacted by the pandemic can tap into some of those funds. But the reality is a lot of these businesses are not coming back. And which ones are not coming back? When you start at the top, and sometimes even at the bottom, it's Black-owned businesses. Those community-oriented places that are not part of chain stores, that are built with blood, sweat, and tears, they are going away, never to come back. And when you take away these small businesses, you take away parts of communities. And so it's difficult for them to make the turn when you are basically running on a shoestring to start with, and COVID comes along and you have to shut your doors. So there's all kinds of moving parts to this thing. And what we're trying to point out to our readers is that all of this works together. You know, there's a history of racial bias that puts people in less than favorable communities. And then when a pandemic comes along, it just makes the situation worse. And for somebody like Dr. Hanchett, you know, who I love and respect, this, to me, it reminds me of another subject that we've talked about in the past, and that's the Great Flu pandemic of 1918. Lots of similarities when you talk about where you live, how you get sick, who dies. And history teaches us a lot of things. And it teaches us, number one, this has happened before, and you're going to see it again. And this is where we are right now. And so that's been our mission, to help draw those parallels between what's going on today, what's happened in the past, and most important, I think, how do we start to work on this? And to me, it's even simultaneously running along the same track as the Black Lives Matter movement itself, because you're seeing a lot of activism in healthcare these days, and people are out in the streets demanding extension of Medicaid benefits, access. There have been instances in Charlotte where people in the Black community have literally begged the hospital folks, move some testing over to our parts of town. That's activism. And that, I think, is part of this story as well. And so it's a good instructional piece for how a community can pull together to get some of the things that we in other communities are taking for granted. And that's part of our mission as journalists. And thank you all for joining us. And just want to give you a reminder to support the Charlotte Post with our local media foundation page on Facebook as well, because this reporting, we're impacted by this as well. And all your support is much appreciated. Thank you.
Thank you, Herb. So we definitely want to get the audience involved in this conversation. So if you have questions, please chat them in. We will get them to the panelists. We have more information to share with you. But certainly, if something you've heard has sparked a curiosity, please let us know. We can get those questions to our presenters tonight. Something you said, Herb, was very key. A couple of things you and Melba both said in terms of zip codes matter. Where we live in this community still matters. And it is really not by accident that there's this disproportionality on the west side of town, where there are plants and where there's a rock quarry. I live on the west side of town, so I am familiar with the issues that are affecting this part of Charlotte. And again, it's by design. We're not having these experiences by accident. You also mentioned something that was really key in terms of activism and what activism looks like. I think oftentimes, we think that activism is only being in the streets and rioting, or being in the streets and protesting. The activism is also being informed in forums like this, and then being engaged with what the solutions could be, which is, as you said, contacting your healthcare providers and saying, we need a mobile testing site on this side of town. We need a mobile testing site here in our community. We need masks. We need protective equipment for people who are being affected by this disease and who also have the conflating variable of not maybe having the resources they need to get some of the assistance they need to protect themselves in this situation. So questions from the audience. What questions do you have of the presenters you've heard so far? We have one question. Can you speak briefly about the healthcare system and the racial disparities during COVID-19? Thank you, Amanda. We are going to get to those questions. So I'm going to say that Dr. Williams or Gibby will be able to address that question for you, speaking to the health disparities along racial lines during COVID-19. Then we have another question. Are there organizations that are actively providing support to the community to get information on COVID, get tested with timely results, getting PPE, or other supports if we are challenged with getting what we need to be safe and healthy? And that comes in from Sabrina. So Gibby and Dr. Williams, you're hearing some of the questions that are being directed your way. Any other questions? So I'm going to go ahead and get started with inviting Gibby and Dr. Williams into the conversation. Gibby, thank you again for joining us for tonight. And as I mentioned previously, we're wanting to establish a baseline ground, sort of framework for this conversation. We have a level of shared understanding. Just curious, before you start with your remarks, anything surprising you about what Dr. Hanchett shared, any of the data that surprised you before getting into the midst of this pandemic? Did you expect the disproportionality that you're seeing?
You know, what I will say is that I could easily have let any one of the three people that just spoke do my talk. And the thing that gives me hope about that is that, you know, over the past 30 years of my experience in public health, we've been looking at this data, we've been having conversations about this, but we are at a place in our country where people who are not health professionals know this information and are starting to share this information and starting to talk about this information. And I think that presents us with an opportunity to really do something about it. And I'm encouraged by that. So I want to thank all of the presenters that have talked so far about the focus that they're doing with their work and the light that they're shedding on the issues. I mean, the fact that we are now talking about place matters. Where you were born, where you live, where you were brought up really can make a difference, not just in your life in general, but specifically in your health. So I'm just really encouraged by that. I mean, the other point that I want to make is, Tiffany, you mentioned the issue of disparate outcomes, and you mentioned health, but I want to make sure that everybody understands that all of the other outcomes that you mentioned directly impact health. So where you live, how you live, what your housing situation is, what kind of education you have access to, what kind of jobs you have access to. One of the things that we're seeing, I think, with COVID-19 is that the folks that are most affected by this are our essential workers. Those folks that are the service workers, the people that are out there with the public being exposed day in and day out. And quite often those are people of color because those are the jobs that they've had available to them. And so I do think that all of those things really impact what we're seeing with COVID-19. I did have a couple of slides to share. It's probably, if you've had I won't say the opportunity, but I have been on TV quite regularly with this data. And, but I did want to point out a few things, if the slides can be pulled up, just as part of this conversation, and not everything that, that we've been talking about. But as you can see here, all of our populations are differently affected by this infection, by this virus. And a lot of that has to do with the types of illnesses that these communities experience, the fact that many of our African Americans at a young age are impacted by chronic diseases, and that, you know, as we look at the spreads here, we're seeing younger populations in our community being affected by this. And that goes back to the service workers, the people that are out in our communities being exposed daily. But we're also seeing, especially in our African American community, younger people being affected by chronic diseases, which puts them at higher risk for infection, but also for poor outcomes. Next slide, please. Oops, we lost a slide. The other thing that I wanted to mention is that if you look at where our cases are in terms of age as well as African Americans, you know, we saw a huge spike in the African American community sort of early on in the April-May range of this pandemic so far. And as you can see, that percentage has dropped somewhat. And we've seen more within the Hispanic community, and some of that has to do with the work that they do, but also the large families that live together are impacting that as well. But we still see that our African American community is more impacted by this infection than whites, which is, you know, unfortunately, what we are seeing with COVID is it just is shining a very bright light on the health issues that we already know that we have in our African American community. It's just exacerbated things. It's not new. There's nothing genetically that I'm aware of at this point. Dr. Williams might correct me on this, but nothing that I'm aware of at this point that makes them more susceptible to this virus. The situation is it's exacerbating what we're already seeing in our community. And there was one last slide that I wanted to point out that really goes back to the whole comment about place matters. You look at the dark spaces on this map and you think about where our poor communities live, and quite often those are African Americans, and you see that that plays out on this map as well. So I'm not gonna spend a lot more time on this because I think there's a lot that Dr. Williams can say about healthcare in particular, and I want there to be plenty of time for question and answer. But the last thing that I will say is healthcare is important, and we have to focus on the issue of access because the African American community does not have consistent and good access to health care on a regular basis. But I also want to reemphasize the fact that healthcare is a percentage of the impact on health for all our community. It's not the biggest percentage. And if we're not addressing those social determinants that we talked about earlier, and that is the harder thing to do because it's a much bigger thing for us to get our arms around. And it goes back to systemic racism. It goes back to the policies in our systems. And there's lots that we have to change around that. But if we don't get a handle on that, we're going to continue to deal with diseases as they come along rather than getting ahead of this so that we can have a healthier community in general, but specifically in our African American community. So I want to make sure that we stay focused on those issues as well as access to health care moving forward. So I will stop at that point. Thank you.
Thank you, Debbie. That's part of the reason why when the Charlotte Post Foundation created this framework, we thought about it in the 4 areas. And there are 5 social determinants of health, but recognizing that the degree to which Black lives matter is impacted by the degree to which we're focusing on all of those aspects of our lives and not just one. So it is very important that while we're talking about health tonight, we also have to be talking about workforce development and having people have access to insurance, people having food and not living in food deserts, all of these parts and pieces and characteristics of our communities that impact ultimately our health. I wanted to ask you 1 or 2 questions. One was around the question we have from Sabrina, who asked, are the organizations that are actively providing support to the community to get information on COVID. I know that the hospitals have provided some mobile testing, and they have provided some masks in the Greater Heights community where I work. So I was curious about that, if you could address what's happening there. And I'm kind of curious to know, given to your point, what we are seeing is just magnifying what has always been there. What has changed with the health department with respect to providing services to communities of color? Like, what practices have you changed internally even?
Those are a couple of big questions. So there are a number of organizations that are providing support to communities through this COVID situation. I will say within our department, we have reassigned quite a few staff. We have almost 200 people every day working on this issue with our contact tracing, case investigation, communication, and as well as some social workers who are working with individuals. You mentioned the fact that, you know, people need to be able to isolate and quarantine. Well, even if you do have a house, if you don't have food in that house and we ask you to stay at home for 10 to 14 days, that's a challenge. So we do have social workers that are working with individuals in those situations to try to help them access food. I'll also say that through our Emergency Operations Center that has been open since March, there have been a number of partners that have come together and developed some safety nets for individuals. We've got a very large volunteer organization that's run by BOAD that and is putting together resources on a regular basis. They've done a lot of work with the food banks to make sure that food is available to individuals. And then there are also services that are being provided to people to help them with issues like evictions. And some of the, you know, the challenge is some of this are ongoing issues for people. They're not new, but how do we deal with the emergent things that are critical for people right now in the moment? The other issue, obviously, is unemployment for people. And so there are a number of different efforts going on there. The county has implemented some things with funds that have come down through the state around housing, as well as trying to support some of the businesses that you mentioned, as well as working with organizations and getting funds to them so they can better serve people. So those are some of the things that are happening in the community around that. And I know that we've got a lot more work to do and a lot more people to engage around that work. Within our department, a couple of things. Number one, we have been putting over the last couple of years some significant emphasis on looking at inclusion, looking at racial equity, making sure that there is a health equity lens on everything that we do. We have been working we've got several initiatives. Village Heartbeat is one that a lot of people know about that specifically works with African American churches to try to help in the area of chronic diseases. And we're having conversations about how we might be able to expand that model to address other issues in our community. We had started having some conversations in our community around violence. Our county commissioners decided, had a proclamation that violence was a public health issue. One of the things I want to emphasize is that our health department is sort of the hub of public health in this community. It is not the public health system. The public health system involves our hospital systems, it involves our nonprofits, our churches, it involves anyone who touches folks from a public health perspective. So part of what we are focused on right now is how do we become a facilitator and a convener to bring people together around public health issues. And obviously COVID got in the way of the discussion around violence. We're starting to pick that one back up again. And the other issue that the board recently addressed was the issue of racism as a public health issue. So I think there's opportunity for us to have a lot of conversation about that. But if you think of public health broadly, in terms of how it, and unfortunately I live right across from one of the hospitals, so I apologize for the sirens. How do we engage the community around that? If we're looking at the community as the public health patient, we've got to address all those issues broadly. The health department can't do that on their own. So that's where a lot of our efforts have been. But internally, we are really trying to make sure that our policies, if we have policies that have that are racist or that limit people's access, we are taking a very close look at our policies and making sure that our systems are what they need to be so we can provide the best possible service. And our county as a whole is doing that, so we're part of that process as well.
Thank you for your response, and thank you, frankly, for calling out very explicitly if your policies are racist. You're taking a look at that. I think in this moment, we need people to be that explicit with what they are attempting to do to unmask, uncover, and dismantle, again, the systems that are producing these results. We're going to turn to Dr. Jerome Williams in just a bit. And Dr. Williams, you already had a question come in through the chat about racial disparities in the healthcare system. And Black Lives Matter Charlotte a couple of years ago did a talk with Dr. I'm going to mispronounce his name. Dr. Ayele. And yes, Dr. Aluko, my apologies. And he shared with us then really some somewhat surprising stats and facts around healthcare and the degree of disparities that exist in the delivery of care. So would love for you to touch on some of that in your remarks and in addressing some of the questions tonight. But let's get into what is going on in the healthcare system, particularly the one that you represent, with respect to the pandemic and the disparities that we're seeing.
Well, thank you for having me on this panel. Thank you, Gerald and Bob Johnson and all the family at the Charlotte Post for all the work that you've done over the years. Can you bring my slides up, please? Anthony, are you able to bring my slides up, or do you want me to share my screen?
I think you might need to share your screen.
Okay, fantastic. If you go to slide 1, please. So as mentioned, I'm Dr. Jerome Williams, Senior Vice President for Consumer Engagement for Novant Health. And in that role, I'm responsible for our community wellness, community benefit, corporate social responsibility, and community engagement program system-wide, the strategic design and development of those programs. Next slide, please. And what I've been asked to discuss this evening is a bit about the private sector as it relates to COVID-19 health care and health inequities. And I am approaching this not only from a physician, executive, and leader within Novant, also as an employer, right? So Novant employs about 30,000 individuals, and many of those individuals are frontline workers that live in the communities that we're talking about. So it's not only I'm speaking from the perspective of a healthcare leader and physician, but also as leading our team members who are in many of these areas that we're talking about, and we're going to get into that shortly. When we talk about organizations, whether it be the healthcare sector or whether we talk about financial sectors, whenever we talk about the private sector or businesses engaged in our communities, it really should start with the intentionality behind the organization and the intentionality behind their work. And when you look at the mission, vision, values of Novant Health, our mission is to improve the health of communities one person at a time. But that is not, to me, one of the most important parts of this slide. One of the most important parts of the slide has to do under the value section. And most people would say, oh, well, diversity and inclusion, yes, that's very important. But to me, courage is the most important word in that listing, because it will take courage, and within our system, it will take courage within our communities to challenge the systemic problems that we know are there. These problems are not new, as Gibby and others pointed out. As Tom pointed out, they're rooted in intentional decisions and policies and behaviors. And to be quite honest with you, the system is working just the way it's set up to work. Okay, it's been set up to work against people of color, and it's working beautifully. And so what we have to do, both as individuals, on the individual level, community level, and the system level, we have to have the courage to push the envelope to challenge ourselves and our organizations to do better. Next slide, please. When we look at what we're engaged in Novant Health, it's a very intentional activity to achieve health equity in all communities, And you have to have a vision, okay? And that's an aspirational vision. You have to have a North Star that you're shooting for. And as we attempt to shoot for that aspirational vision of achieving health equity, we're focused on upward mobility, okay? And interestingly, most people are probably saying, well, that's not a health-related aspect. And I would argue, yes, it is. It's very much a health-related aspect. And if we focus on upward mobility and other non-biological and genetic factors, I think we'll get much more traction. Our community engagement team is charged with not just strategically laying out these programs, but monitoring the programs, monitoring with data, pivoting, and going in different directions if the data suggests that we're not going in the right direction. Next slide, please. I'm going to go a little deep here on our framework. And why is this important? Once again, if you're looking at organizations, businesses, companies, private sector, there has to be an intentionality behind engaging in communities. It can't be haphazard. It can't be, we're going to hire an African-American to run a particular program. You have to bake equity and inclusion throughout everything that you do. And so when we look at this strategic framework that I'm going to go through, this is baked in everything that we do. It's not a program, it's not a project, it's baked throughout the system. And when we look at logic models, when we look at theories of change, typically theories of change and logic models are very linear. You have some inputs, you have some activities, you have some outcomes, and then hopefully you create change. But when we talk about achieving equity, it's complex, it's multi-layered, and it involves many different aspects that have to be addressed nearly simultaneously. So what we've done is we've created a framework that is viewed in concentric circles that takes into account all of those aspects. And on the outer circle, as you can see, and Tom spoke to this beautifully, are confronting deeply rooted structural inequities and biases, which is deeply rooted in legislation, which is deeply rooted in policies. And so we have to understand that's the foundation that we're dealing with, and ultimately we have to change those structures. When we look at the next circle, community-driven solutions, far too many times there are organizations that go into communities, grab data, and exit communities, but they don't listen to the communities. They don't listen to the communities. And if you listen to communities, often a number of the answers and solutions to the challenges are right there in the community, if you just take time to listen. Now, some of those solutions may require a business plan, may require financing, may require some type of partnership and support, but often those answers are already in the community, and we have to go and listen to them. We have to address the social determinants of health. 20%, only 20% of our health has to do with biology and genetics. 80% has to do with the 9 different social determinants of health: upward mobility, lack of access, lack of opportunity to obtain food, housing insecurities, unsafe neighborhoods. Those factors, and also behavioral aspects, those factors influence the health 80% of the time. So if we're talking about improving the health of our communities, it's not only about adding another clinic. It's not only about adding more doctors, more nurses. It's really looking at structures and organizations that can also focus on the social determinants of health. We follow 5 strategic priorities. Access. So access is easy. Everybody thinks of access as access to healthcare, whether it be virtual healthcare or whether it be brick and mortar. We're talking about more than that. We're talking about access to capital, okay? Access to social capital. So some of the initiatives that we're engaged in, besides opening clinics, besides virtual care, is working and partnering with Mechanic and Farmers Bank to support loans to minority-owned businesses that do business with Novant Health. That's a different type of access, not just healthcare access. We have to have access in many different ways. We have to, once again, listen to the community. The community voice is very important. Partnerships. Okay, healthcare systems, we are subject matter experts in healthcare, but we are a public trust, and we are anchor institutions. And so we have to provide, as Gibby said, a platform of partnerships to engage other subject matter experts in housing and food and employment so that we can figure out different innovative ways to bring solutions to our communities. Number 4, measurable impact. We can no longer do good and feel good. We have to demonstrate impact. And if impact is not demonstrated, then maybe we have to look at different tactics. We can fail fast and pivot. That's okay. These are deeply rooted problems that if we had answers to, we would have solutions for already. So we have to look at a measurable impact. And when I say measurable impact, I'm not talking about return on investment in financial terms, okay? There are terms such as social return on investment, connecting lives, patients to medical homes. Those are measurable impacts. And lastly, when we look at our strategic priorities, we talk about capacity building. Not only capacity building internally within Novant to activate 30,000 employees to be ambassadors within their communities, but we also have to build capacity in communities for them to advocate for themselves. I forgot who mentioned earlier that there are certain neighborhoods that have certain things because they know how to advocate for themselves, because they've been at the table. They know how to be at the table. They're not excluded. And we have to understand that to sustain the changes that we all aspire to make, we want to ensure that our communities have a capacity over time to advocate for themselves and have agency for themselves. And if we're able to do a lot of those things successfully, we'll have improved health outcomes, upward mobility, and health and wellness for our communities. So that is just a framework of activities that we're engaged in now. I can list a bunch of tactical activities, whether it be mobile testing, whether it be opening up clinics, things of that nature. That's great fun and well. However, the point of this slide is the intentionality behind how you engage in the community and set up a framework so that it outlives individuals, right? It outlives an individual, because the problems and challenges that we're talking about will take decades to achieve. And so we want to create a foundation that outlives just the panel right here. And on my last slide, since we talked so much tonight about maps, our COVID-19 work, while there's a lot to be done, a lot more to be done, intentionally target, once again, historically excluded areas. And through partnerships throughout the communities, we're able to deliver not just education and testing and mass distribution, but also, and more importantly, develop trusted partnerships. The way we go into communities is not going into communities as a huge institution that knows it all. We go into communities, first of all, and ask, can we participate? We identify through the community conversations that we engage in. We ask for feedback. Who are your leaders in the community? Who do you feel has your voice? And then we partner with those individuals to roll out programs and activities. So when we had our mask distribution campaign, where we distributed close to 500,000 masks throughout our historically excluded communities, it wasn't that we selected communities to go to. We tapped into our partners and said, hey, where are the best places to go to distribute masks? Where is the need greatest? And through those partnerships and leveraging those partnerships, we're able to deliver service. There's still a lot more work to be done. This is a journey. As I mentioned earlier, the vision is to achieve health equity, and that's a journey. And we're well into this journey. COVID really peeled the scab off of challenges that we know were there before, challenges that we've been addressing for years, a lot more work to be done.
Thank you, Dr. Williams. And what you just ended with sort of leads me into my first question before I get into some questions from the audience. Individual, system, community. You've touched on it, but I want you to reiterate some of the actions we can take at those three levels of change. As individuals, what can we do? As a community, what can we do? And then what do we need to be doing to change the system?
So on an individual level, okay, there are many different behavioral activities that are personal, right? So there are activities that impact your health negatively, and they have to be addressed, and those are personal decisions. Tobacco use, just to name, one. Now, I will also say that when you look at nutrition, okay, individuals buy food based on location and what they can afford.
Yes.
Okay, so there's one thing to say, hey, we need better nutrition, but you have to go 10 miles to the nearest grocery store to find a head of lettuce or tomato. Okay, so we have to solve for that. On the community level, I feel there has to be greater empathy. There has to be greater empathy. We, as Gibby outlined earlier, this data for healthcare individuals are not new. In the early 80s, late 70s, early 80s in college, when I was studying this, we call this community health and social medicine. Now it's called social determinants of health. It's really the same concept. What's different now, I believe, is that there's a greater awareness in the lay public about these factors that are non-biologic and non-genetic. And so that's what we're really seeing. So as a community, we have to show more empathy because some have privilege and some do not. Now, on a system level, I go back to courage. And this is where I think that I'm proud to be part of Novant. They took a hard, long look in the mirror. Okay, I should say we took a hard look in the mirror years ago. We looked at our workforce. We looked at where the communities that our workforce is coming from. We looked at the health of our workforce. And it was an intentional decision that we have to put together a framework, a vision, strategy, and tactics to address a number of these issues. So on a system level, the systems have to be challenged. They have to be challenged internally. They have to be challenged externally. And where the courage comes in is those internally in places of influence. We need to leverage that influence and have the courage to bring certain discussions into the room and challenge historical norms.
Thank you. We have a question in the chat that's along those same lines in terms of wanting to know what types of solutions is Novant Health working on to ensure the bedside staff is not adding to the racial disparities, given that we know that these exist within the healthcare system. Mm-hmm. What are they doing to ensure that bedside staff aren't compounding the problem?
So fantastic. So throughout Novant, not only do we have cultural sensitivity programs for all of our providers. And when I say cultural sensitivity training and program, it is not only as it relates to African Americans, but we have significant Latino community. We have a significant Asian community, LGBT community. And so we have a structured program that every clinician and provider and administrator must go through. And once again, I go back to the original slide, the very first slide, which is the intentionality behind this work on a systems level. Okay, in order to have these types of changes, it has to be not a program, not a project, but baked throughout the system. I'll give you for an example. When we opened up the Novant Health Michael Jordan Clinic on Freedom Drive, health equity was baked all throughout that. So what do I mean by health equity was baked throughout all of that? When we look at the architect, identified minority owned firm. When we look at the builder, when we look at the artwork and artifacts that go into the center, we went to the neighborhood and canvassed for vendors, artists, artisans within the community. Why? because once again, it's not just about putting up a building, right? It's how do we engage in the community? How do we engage not just from a health care standpoint, but from an economic standpoint, from a social capital standpoint, and how do we assist the community in creating capacity to advocate for their needs?
So we have questions coming in through the chat, and so I want to continue to get the audience involved in them, in the conversation. One of them was around COVID-19 on mental health. Did either one of you, Gibby or you, Dr. Williams, speak to what's the impact on mental health, knowing that I think, again, as we've already alluded to, the degree to which Black people, communities of color access mental health care or have access to mental health care is disproportionate. So there's that underlying context. So can you speak to the impact of COVID-19 on mental health? What are you seeing? Gibby, I think you're answering, but you're on mute.
You're on mute, Gibby.
Gibby, you're muted.
Yeah, I had to, sorry, I had to wait for the host to unmute me. I was punching the button and nothing was happening. I've said I'm going to go to my grave being muted. That's probably the hardest thing about all of this. You know, we are very concerned about mental health issues related to COVID. I mean, when you look at the stressors that our community is experiencing, whether that's homelessness, whether it's the potential for eviction, whether it's the concerns around joblessness, whether it's concerns about what you're going to do with your kids because you need to work and they're going to be at home all day long. I mean, all of those sorts of stressors are out there, in addition to worrying about whether you're going to get COVID and be ill, or whether your parent is going to become ill, or those sorts of things. So we know that the impact on the mental health of this community is significant. And unfortunately, we also know that the resources available to our community, especially communities of color, to address mental health issues was not what it needed to be before COVID came along. So you put all of that together, and we have challenges. So as we're looking at our data, we're seeing increases in domestic violence. We're seeing concerns across the country around suicide. We're seeing any number of issues like that that are indicating to us that not only are people depressed or you know, having problems, it is exacerbating issues that were already out there in our community. I mean, a pandemic is going to do that, right? I mean, how many times have we had to address a pandemic? So there's conversations that continue to happen around that. There's every effort to try to build some of those resources, but to try to do that in this type of environment is challenging. The other thing that we've got to be focused on, and this is the long term, this goes back to what Dr. Williams was talking about how this is going to take a while. We have got to do a better job of helping our community at the community level as well as at the individual level to be resilient, right? To be able to address issues like this as they come up. And so again, that's more of a long-term piece while we're trying to address the individual issues that we have. But unfortunately, what we do know in our community is there's just not enough service to go around.
Thank you. A couple more questions from the chat. We have one from Mike. I'm going to summarize it a little bit, but it's around schools. A large portion of population who work in service areas may need to return to work. With elimination or reduction in COVID bailout benefits, do you think services are in place to support the students? And how can we avoid widening the education gap?
I'm sure Dr. Williams and some of the other panelists have some thoughts on this as well, but I am incredibly concerned about our students and about the education that will be received this year. I understand the decisions that the schools are making. I understand the decisions that the governor made based on COVID and the concerns we have around the spread in our communities, especially in Mecklenburg County. I mean, we topped 200,000 cases today. We topped 200 deaths today. So we know we've got an issue in this community. But I am concerned, the issues that we've been talking about and about the fact that COVID has exacerbated things. We have kids in our community who do not receive the same level of support around education. And they tend to be in our poorer communities. They tend to be in our communities of color. And when we keep our kids at home and they need to be virtually educated, their parents are working one or two jobs, these kids are going to be sort of left to their own devices to try to do the best they can with their education this year. And my concern is that they're going to get further behind. The other thing that we're concerned about right now, because we've not been able to keep up with immunizations because of COVID, is we've got an issue there, which could create all kinds of problems on top of COVID. We've got a flu season coming up. We need people to get vaccinated for flu. So we are working to try to get our children vaccinated now that we know that the schools are not going to be open at all. We are repurposing our school nurses to focus on those kids in their schools that are not vaccinated. We're talking about possibly having clinics specifically for each school and contacting those kids and getting them in to get vaccinated. So there's a number of issues, but I'm just not sure there's going to be enough resources out there to help kids with their education this year. That is a major concern.
I'd also like to add, when we deployed our mobile units to historically excluded areas and brought healthcare services, and we ramped up our virtual health services, which deeply penetrated into a number of our historically excluded communities. What we also discovered, and once again, this is where listening to the voice of the community is imperative. As we went into the communities and provided those services, what we also heard was, okay, this is great, but I don't have Wi-Fi. This is great, I don't have a laptop. And so the digital divide that we already knew existed, okay, it really exploded even further with the explosion of virtual healthcare and virtual services. So we're looking at a pilot now of trying to bring not just, once again, healthcare, but bring digital services and technologies to these communities as well. So this is a complex problem that, as Gibby said, I don't want to be an alarmist, but I unfortunately see some greater challenges based on what's going on right now. And with the disparities we know, and the inequities that we know exist between schools, right? There will be a segment, unfortunately, that don't have the same access as other communities to educational services, and that's going to be a challenge, and we have to address these.
If I could jump in, I actually have some information about the digital divide issue and students getting access to digital resources. I only have a little bit of information, but I think it's new to most of us. My wife is Carol Sawyer, and she is on school board, and the issues of equity are something that literally keeps her up at night. And one of the bits of good news that everyone should know and tell your neighbors, CMS now has iPads for every single K1 and 2 student. They also have Chromebooks for every other student, grade 3 through 12. And many students already have those. They also have Wi-Fi hotspots. You can get online. And how do you get those? Carol Sawyer from School Board says, be sure that the kid's current address and phone is with the school, because the school is going to reach out as they start in the next couple of weeks. They're going to send a letter, they're going to make a phone call, and kids move around. And maybe you know some folks who have moved over the summer or moved in the last week. If you can get their name and address to a school, that helps the school system keep track of them on a whole bunch of different levels, but also it will give them some of the tools. It's not all the tools, but the physical tools that they need to get on the internet they're there. And so I'm very impressed with that with CMS.
That's great news.
Thank you for sharing that. I know in Greer Heights neighborhood where I work, we had a lot of students who perhaps had laptops but didn't have Wi-Fi, or if they had both, they still needed the support from a caring adult to help them navigate math and English and school as we now know it. And so what this is going to look like this year and the effects of this on our students is really one that we will see for another year or so to come. So the education piece is still something I think we're all sort of spending a lot of time trying to think about what is the best solution given so many unknown variables. I wanted to ask another question of the panelists, and we have a few still in the chat from our audience members. One is around how can our community contribute to improving access to service? And this particular question was around alcohol and substance abuse, but I would venture to say it's really around all of the other areas of health, mental health included. How can we contribute to improving access to services? Is it a structural issue? Is it a policy issue? Is it an employment workforce issue? Do we not have enough people? What is the quote unquote the problem in terms of improving access? And that could be to Gibby or Dr. Williams, Dr. Hanson, if you have a perspective as well.
I'm sorry, I was muted. So there is a platform that we utilize at Novant Health. It's called My Community. And that platform is a platform that links social services, partners in the community that provide social services to those in need. North Carolina just rolled out a similar platform. It's called NC Care 360. And what that does is if an individual comes in and say they're homeless, okay, that platform can then, by zip code, you can find which agency locally can assist that individual in providing services. In this particular case, we're talking about a home, and close the loop with that individual. Now, that service is relatively new. We need to get that information out. That service is not just provided through Novant Health. You can go online as well. Once again, online, if you have a computer, if you have access to Wi-Fi. It's called Aunt Bertha. That platform is called Aunt Bertha, and also NC Care 360. So we have to do a better job of communicating the services that are there and underutilized, because there are many services out there, but we need to connect the dots and connect the people to those services.
Yep. Tiffany, you're muted.
It was my turn to be muted. So I'm going to ask a question that's related, perhaps not squarely on the topic of health, but I will say as a Black woman living in this moment in time in our individual collective history and our shared experiences, I'm experiencing a degree of trauma. The death of George Floyd, and someone said this the other night, was traumatizing to that individual. And I hadn't used that word, but hearing him describe how he was feeling, it was a traumatic experience for a lot of people, and certainly for me. And so having this conversation tonight around health, we have talked about race and racism, but I kind of want to know what is it feeling like for you as a practitioner being in this space and place of health and public health in the wake of what has happened to this country in the past few months, the past 45, 50, 60 days. Has something shifted in you with regard to how you're approaching your work, your mission, what you're trying to accomplish?
Jerome, you want to start?
I'm sorry.
Go right ahead.
Ladies first. So, first and foremost, personally, I was not activated anymore by George Floyd than I was by Breonna, by Eric Gardner, and the list goes on and on and on and on and on. What has changed for me, I would tell my team at Novant that if you remember that framework that I put up earlier, the outer circle was structural biases and injustices. So what Tom spoke to, which is structural, racism. I would tell my team historically, we're going to work on all of these spheres, right? Concentric spheres. However, the one that's going to be the most difficult and the last to change will be the outer sphere, which is structural. Since social unrest, since George Floyd and the awakening of the rest of America, I now see a real possibility of attacking structural inequities, very much a realistic goal. Very much a realistic goal. I thought that was a long-term goal, but now I have the feeling, faith, desire that we need to aggressively move now to address the structures and not wait for addressing those structures in a meaningful way long term. I think it's accelerated that. So from my perspective, that has been accelerated and plan to leverage partnerships and opportunities to make the change on the structural level now that we have this opportunity.
And I'll reiterate, I agree completely with everything that Dr. Jerome said. I think personally, I have to admit that it's frustrating that it's taken this to get us to this point. But I have to get past the frustration. And the one word that I will add to what Dr. Jerome said is hope. I hope that we can move things forward and that there is enough intent and there's enough desire and there's enough drive in all of us right now to make the difference that's going to help move that forward and make those changes that need to be made. Unfortunately, we've known about them. We talk about them. How many years have we been talking about the structural racism and the changes that need to be made? But it just feels like now is different. And shame on us if we don't take advantage of that.
Absolutely.
That's well said. I can't add anything to that. Both of you, thank you.
Herb, Melba?
I think that when you get right down to it, it's a matter of will. Not just will anything happen, but I'm talking about political will and community will. When you talk about, we've talked about these inequities for years, that's true. But I think that there's also been a good chunk of Charlotte and America that has poo-pooed the whole thing. The bootstrapping again, when empathy, could have been put to use to help everybody rise up a little bit. So I think that is the word. I mean, hope is great, and all that other good stuff. But I think will, the active verb, is what's needed now.
Agreed. Melba, any thoughts?
If I can get in. Yeah. In addition to, Herb is right, the will, but not just the will to return to a kind of, a more status quo thing, the will to lean in and to seize this moment to accomplish everything, not to be constricted by, well, we shouldn't go too far, because we see that you're not given a chance to accomplish these things very often. And when you do, you have to push as hard as you can to get as much as you can, because after every period of progress, there comes a period of backlash and retrenchment where people try to move you back. So instead of settling for a half cup of what we do, instead of talking about, well, we got to do something about this deficit that we didn't have anything to do with creating, we have to take advantage of this moment to invest in our priorities, which is healthcare and equality and justice and whatever that costs.
Thank you. We are still open for questions from the audience. If there are any that you all would like to pose or chat in, please send them our way. I think we might have answered most of them. We had a question about sharing resources. We will share this information. We are planning additional conversations around Black Lives Matter Charlotte issues. The one that I am intrigued by is the notion of race being a public health issue. I don't know exactly what that means. Our response would be, once you declare it public health, like then what? What goes on after that? So I'm curious about that, and Debbie, happy if you want to touch on that a little bit to share perspective on that particular aspect of what we're doing now in response to where we are.
You know, when we talk about race as a public health issue, I think what we're saying is that the racism is a public health issue. Race is not. So I want to, be clear about that. But I think what we're talking about here is the impact of racism on the health of our community. And when I say the health of our community, that includes the physical health, the emotional health, the spiritual health, the economic health, all of those issues, and the impact that racism has on that. And by recognizing it as having that level of impact on all parts of our community, it gives us an opportunity to develop a framework for how we're going to address those issues. It goes back to what Melba was just saying. It gives us an opportunity to look at all of it and grab as much of it as we can and address as much of it as we can now that we have the opportunity before that opportunity goes away. But again, going back to what Dr. Jerome said as well, that's not going to happen unless we engage our community in that conversation and unless we make sure that our community is help driving what needs to happen to make those changes. So it's not a simple, just by claiming it as a public health issue is not a simple fix, and it's not a short-term fix. It's a start, but I do think there's a lot of work to do.
One of the things that I would hope would come out of this is a wider understanding of how connected we are. And we've had an ethos in our community for, in our nation for decades now that, that my good is what's important to me. And I hope that what we understand coming out of the COVID thing is that my neighbor's health determines my health. And I may not be African-American, I may not be Latino, but if those folks are sick, I'm going to get sick. And we have made decisions not to extend healthcare widely in this nation, and many other decisions that basically revolve around, I'm all right, not going to worry about those other folk. We're at a moment where the virus is showing us that doesn't work. I hope we learn that lesson.
That is a very, very insightful response. I think in this moment we're learning just how much we are really, truly interrelated and interdependent and connected. And my health, my life does matter, and it impacts yours. So us feeling that and believing that is really, really very important. So thank you for joining us for this conversation this evening. We are delighted that you were able to spend this time with us, sharing information with us, sharing wisdom with us, giving us your perspectives, helping us get grounded in history and place, helping us hear stories about people who are being impacted now, and giving us perspective on policy and practice that we need to be thinking about as we move forward collectively, not just in light of this pandemic, but in light of, again, this moment we are in collectively in our history and the community, and the country and the world, in fact, with regards to Black lives and the extent to which they really do matter. I'm going to turn the conversation now over to Gerald Johnson so he can close us out for this evening and share any other information that he needs to present to the audience.
thank all of you all for attending this event this evening. And the panel, I want to thank you as well as the journalists. That was an intriguing and very interesting conversation. And we will have future webinars coming up, hopefully in the next several weeks. We will put on another webinar that's going to cover same sorts of topics here. But we did part of this was a fundraiser as well, and my great technician didn't show the video, at least I didn't see it, so I don't know if you all saw it or not, but we had a piece where we, because of the COVID-19, we were impacted by just as much as anybody else. And we had a piece down to donate tax-free for just helping us get through this COVID-19 along with everybody else. And that was missed. We will come back and pick that up later. And I see a couple of other questions that didn't get covered, and I don't know if we want to cover those now or not. But anyway, since they gave it to me to close out, I will do that. Thank all of you for coming this evening. We appreciate your time, and please make any email us with any comments you might have going forward, and even email us about any topics that you would like to see covered. I see Mr. Eastman asked a question about mental health, and are we going to get involved with that at all? And that is one of the topics that we are reviewing to get into, because we've been asked about that by several people. And so, yes, we will get into that in one of these webinars in the near future. But again, thank all of you for attending, and we will talk to you later. Thanks. And Tiffany, thank you for a great job.
Thank you. Good night, everyone.
Good night. Thank you.
Thank you, Tiffany, for a job well done.
Thank you. I couldn't see the video at the beginning.
I know. I don't know what happened to it, but
That's why I was sitting there looking.
yeah, I thought it was transmitting, but it was not. So I tried to get it on at the end. But all right. So I guess we'll chat offline. I'll give you a call. Thank you. Good night.